For the next session, I would like to invite Dr. Amala Selvam A., Consultant Physician and Diabetologist at Joseph Medical Center, Bengaluru, and Dr. T.J. Pradeep Kumar, Consultant Physician and Diabetologist at Brookfield Hospital and Medicover Hospital, Bengaluru. We welcome you all.
Stage, doctors.
Good afternoon. I welcome Dr. Bobby K. Mathew. The next topic is about metabolic syndrome and erectile dysfunction. So the most commonest thing which is encountered among metabolic dysfunction patients, but very less spoken about it because of the patient and doctor's conversation between this topic. So to talk on this, how to interact with patient and to understand, I hand over the mic to Dr. Bobby.
Something about erectile dysfunction. We have only 20 minutes. I was just touching and finishing. We are only few people here. Basically, open Harrison, what's the definition of erectile dysfunction? It is defined as the inability to attain and or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. That is, if a person is not able to attain an erection, that is ED. A person is able to attain an erection, not able to maintain that erection, that is also ED. A person is able to attain an erection, maintain an erection, but not the sufficient rigidity he wants for a sexual intercourse, that is also erectile dysfunction. A person is able to attain an erection, maintain an erection, that too of the sufficient rigidity, but his partner doesn't get a satisfaction out of the sexual act, then also the performance of erection has failed, that is ED or erectile dysfunction. Don't look at the slides, just concentrate on me, I'll be just finishing. So what is ED? Inability to attain and or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. Previously during our MBBS MD days, ED was known as impotency. Harrison's second volume, second chapter was always on impotency. Now we never hear the term of impotency because NIH guidelines 1992 has removed the term of impotency because addressing a guy, a young guy, 35 years having a premature ejaculation or having a road traffic accident, paraplegic, having an erectile dysfunction, you address him as an impotent male is thought to be a great insult to manhood per se. So the modified term of ED or sexual dysfunction. And always understand, age is the biggest risk factor of ED. Only 10% of men less than 45 years have organic ED. A physician, endo or uro sitting in an OPD, 10 people, 30, 35, 40 years come to the OPD and tell of sexual dysfunction. Only 1 in 10 have organic ED. Remaining 90% are psychogenic ED, most commonly premature ejaculation. But as your age increases, 50% of men above 60 years and 80% of men above 80 years have some sort of erectile dysfunction. That never means that a guy of 80 or 85 years is not able to have a sexual intercourse with his partner. He may be having rigidity sufficient enough to have an intercourse with the partner. He may not be enjoying that rigidity which he used to enjoy before the age of 50 years. So just understand, erectile dysfunction is not a total lack of erection. A guy comes and tells a doctor, I had intercourse with my partner 2 weeks back, now totally I have lost my erection, treat me. That itself shows a psychogenic ED. Sugar, BP, cholesterol, anything goes an ED occurs over a year of 5 to 10 years. A person with diabetes, the erectile dysfunction starts at 45 years and it progresses slowly. So basically understand, always I say whenever I go for any talk, females always have a doctor to see. That's known as a gynecologist. Suppose my wife is 42 years. She is missing menses for 3 months. She has done a laparotomy or whatever mini lap has been done. She is not getting pregnant or a marina is inserted. So if she misses her menses, she goes to a gynecologist. Gynecologist will again go for a urine pregnancy test. That is negative. Gynecologist will do an ultrasound for a late onset polycystic ovary over FSH, prolactin, TSH to find out a premature menopause, hypothyroidism or a hyperprolactinemia. Suppose a doctor sitting here or any person 45 years is having a poor erection. He thinks that he is not able to attain and or to maintain erection. What will you do? First and foremost, 40 45 doctor or 50, 55, suppose 75 doctor sitting here, he will not do anything. He will think that it's a process of aging. He will think that my age is 75, I am having grandchildren, my wife is 65 years, I am having sugar, BP, cholesterol or tablet for sugar, BP, cholesterol. He will never ever check his testosterone, prolactin or TSH. That is why females always have a doctor to see. That is known as a gynecologist. Men never know and check their hormone anytime. People above 40 years with poor ED, we see them with testosterone 1 or 1.5. The testosterone gel is available. You can apply once or twice daily or a single injection once in 3 months and preserve the erection. They consider it's a part of aging. So that is why whenever erectile dysfunction occurs, we have to take the testosterone, but erectile dysfunction is not totally testosterone related. So understand the concept. What are the stages of male sexual function? First is the stage of libido or desire to have sex. The sex should come from your brain. Once you have a libido, the blood pumps into the penis and penis gets into an act of erection. Third is the purpose of having erection, either an intercourse or a masturbation and ejaculation. So first and foremost, always understand erection is not that occurs in the brain. So previously we used to think that what is the biggest cause of ED? People think that psychogenic ED. Now psychogenic ED is coming down. The end organ of erection is not the brain. Just imagine whatever we have studied in Harrison only, I am telling. So the end organ of erection is not the brain, the spinal cord, your S2, 3, 4 segments or the nerve agendis or a parasympathetic nerve fiber. The end organ of erection is the corporal cavernosal endothelium. We know that the penis is made up of two groups of smooth muscles. A central midline corpora spongosa which bulges and forms the glans penis. On either side there is a pair of corpora cavernosa. So whenever you are having libido to have sex with, your corporal cavernosal endothelium produces nitric oxide, and nitric oxide is the most potent vasodilator in the body. So invariably that is why there are two types of erection. Always understand neurogenic erection and reflexogenic erection. Look at this. This is the corporal cavernosal endothelium. This is the cross section of a penis. The moment you are having a desire to have sex with, we are not having stroke, we are not having paraplegia, we are not having prostate dysfunction. So in the moment you think your corporal cavernosal is intact, it produces nitric oxide. So invariably nitric oxide has to produce vasodilatation and the blood pumps into the corpora. That is known as a neurogenic erection. So always understand there are two types of erection. One is known as a neurogenic erection, second is reflexogenic erection. So think when you are at your teens, 10, 15, 30, 45 years, the moment you think of a female you want to have sex with, the moment you hear the sound of a female that you want to have sex with, the moment you chat with a female or touch a female, you have a tight erection of your penis without even touching your penis. But as your age increases above 50, even the strongest desire or touching of a female or chatting will produce a flicker of movement of your penis. You have to touch and caress your penis via the pudendal nerve. The S2, 3, 4 segments you have to stimulate via the local reflex act to produce an erection. That shows that your erectile capacity has come down. That's the first marker of an evolving heart disease. That is why ED is no longer erectile dysfunction, it is endothelial dysfunction. A person after having adequate libido, suppose a guy 55 saying, doctor, my libido is good, I get so much kick seeing my wife, my libido is good, I am not having any stress, I am married with her for 35 years, what stress with her? I check my testosterone is 4.5. So a person after having adequate libido in the absence of stress with normal testosterone is not able to produce adequate penile erection. That shows that his corporal cavernosal endothelium is not able to produce nitric oxide for penile vasodilatation. That is why ED is the first marker of an evolving coronary artery disease. That is why latest JAMA guidelines say that any person about 35 years come to the OPD and tells that, doctor, I am having ED. You are asking him it's a psychogenic organic. He is saying that, no doctor, my erection was good 5 years back, now it is progressively coming down. No morning erection, no erection sustainability, masturbation, no erection. The first and foremost test is not asking him for a testosterone, giving him a sildenafil, tadalafil, vadinafil. First and foremost, asking you for a TMT echo or a coronary artery calcium scoring with a CT coronary angiogram. That's the first marker that your blood vessel is getting blocked. So understand the concept. The end organ of erection is not the brain, the spinal cord, it's just the endothelium. That is why one guy yesterday, I came from Dubai actually now directly. So one of my patients who was a big businessman who runs multiple cold storage chains in Dubai, Qatar, everything. He was coming and telling me, doctor, of the past 5 years, my erectile capacity is coming down. He was telling the same about neurogenic erection, reflexogenic. He was telling that during his childhood days, our childhood days is same. We are all 45 plus people. We had only Doordarshan. So that time Maradona's World Cup and all 84-85 period, when he used to see the advertisement of Crowning Glory, where Dimple Kabeya comes in, or Little, whatever the soap advertisement, he thinks that his parents were thinking that he was having such an amount of erection that he could not even move till the age of 30, 45, such an erection that even a visual stimuli of a lady or a soap advertisement going produce an erection. Now he's 52. So ultimately, whatever thinking occurs, whatever touching occurs, his penis is having a flicker of movement. Why come? Because his endothelium, he may be having millions of money, chartered plane, everything, but his
HbA1c is 8.2, LDL is 132, triglycerides 452, 3 packets of cigarette and 2 stents in the heart. Then how do you expect the penis to work? Nothing will work. Your money will work. You can't put a crane and make your penis work. So that is why ED should be never be treated. That is the concept of erectile dysfunction and endothelial dysfunction. Understand each gram of HbA1c. That's why men have a disaster. Females are thought to have a disaster of menses and pregnancy. Men have the biggest disaster of ED. A partner demanding sex and the person is not able to deliver sex. That's the biggest disaster in your life. Your partner never demands sex. That's okay. Your partner is there but you're not able to deliver. And many people think that females loses the libido after 40, 50. Nothing. Female libido is not controlled by actually estrogen. Female libido is controlled by mind as well as testosterone. Your estrogen comes down with menopause, but your testosterone never comes down. That is why females, postmenopausal females, 50, 55 years, even after estrogen replacement therapy, if they have decreased libido, give them a small dose of testosterone or DHA tablets, which increases the libido like that. So always understand, each gram of HbA1c above 6.5. Understand the concept. Each gram of HbA1c above 6.5, each millimeter of mercury above 130 by 80, each milligram of LDL cholesterol above 70, each puff of cigarette you smoke is first occluding the narrowest artery in the body. That's the penile artery, which has a diameter of 2 millimeter. Then only your coronary, which has a diameter of 3 to 4 millimeter. Then only your carotid, which has a diameter of 5 to 6 millimeter. Then only your femoral artery, which has a diameter of 7 to 8 millimeter. Just like Rubin Shah, who is thought to be the father of andrology in India, the biggest penile process implant surgeon in British Candy, he was telling that it is just like a water tank filled with dirt. Suppose I am building a new house. I am not opening the house for 6 months. A water tank is there that is filled with dirt. So 6 months after I am coming and opening the pipe, first the water will come directly. After a certain period of time, all the dirt and sediments in the water tank will come and the water will be coming shoo. It is not coming. I take a rod and put it and immediately the water comes out. The same that occurs with HbA1c. Each gram of HbA1c above 6.5, each milligram of LDL, that's the biggest killer of erection. Each milligram of LDL above 70, each puff of cigarette you smoke, each millimeter of mercury more than 130 is first occluding the narrowest artery, that's the penile artery. Then only this gets blocked because this is the narrowest pipe in the body. Whereas you are able to put a stent in your coronary, carotid and femoral, the 2 millimeter cavernous artery, you can't put a stent. You can just give a penile vasodilator of a sildenafil, tadalafil, vadinafil. The sildenafil, tadalafil and your vadinafil may work for 3 to 4 years. After that, your nitric oxide production becomes zero. That is why some people come and say that, doctor, these drugs are ineffective. These drugs are ineffective not because the drugs are bad. Your penis is ineffective. Your endothelium is ineffective. Your endothelium is not able to squeeze out even 1 microgram of nitric oxide. It is not the drug that is working bad. It is a progressive endothelial dysfunction. That is why whenever you take a metformin to keep your HbA1c less than 6.5, whenever you take statin to keep your LDL less than 40, whenever you take a losartan, telmisartan, olmesartan to keep a BP less than 130 by 80, whenever you exercise properly and quit your smoking, you're actually protecting the penile endothelium and any endothelium in the body. That is why recently there was a paper that is published in JAMA. Understand the concept. It is prevention of ED that is important. Just prevention of coronary. We think that atherosclerosis starts in the intrauterine life. And now rosuvastatin is approved about 6 years and atorvastatin about 10 years. And every person in India with lipid profile, you have to do the LPA, ApoB and HSCRP. That's the same concept. The biggest risk factor for heart attack is nothing but LDL, probably add on with LPA, ApoB. That is the same which is the biggest risk factor, erectile dysfunction also. That is why latest there was a study in JAMA, people above 45 years who were taking sildenafil, tadalafil, vadinafil, sildenafil, Viagra 25-50, tadalafil 5 to 10 were divided into 2 groups. One group was asked to exercise properly and lose 10% of the body weight. Another group was asked to continue tadalafil 5 and 10 milligram. People who exercise properly and both groups were evaluated after 6 months. After 6 months, the people who were taking tadalafil 5 progressed to 10 milligram. The people who continued to exercise actually could quit the tadalafil 5 milligram. So actually the lead author in JAMA was asked the question, what will you advise guys above 45 years who come with organic ED? His question was, ask them to exercise properly, never smoke even 1 puff of cigarette or any vaping instrument, throw it out and always take a statin to keep the LDL less than 70 because statins do much more wonders to prevent the penile atherosclerosis than any other process in the body. So understand, it is not the treatment of ED that is important. That is why understand previously it was erectile dysfunction, now it is known as endothelium. The endothelium is not working. So whenever a guy comes with a coronary artery disease, you know that penis is getting blocked. Whenever a guy comes with a penile dysfunction, you know the coronary is getting blocked. And what are the routine tests to do in a guy with organic ED? Suppose a guy above 45 years comes and asks you, Dr. Bobby Harrison, or ECNA, what are the routine tests to do? 5 tests: FSH, LH, testoprolactin, I told you, T3, T4, TSH, lipid profile, LFT, RFT, HbA1c, and PSA age more than 40. Always understand, men always miss the hormone. I told you first itself, because females, once they miss the menstrual cycle, they go to gynecologist do a ultrasound or an FSH, prolactin, TSH, and menopause is a reality. What is menopause? Permanent cessation of menstrual cycle after the exhaustion of the ovarian follicles, which is diagnosed 1 year after the last menstrual cycle. So a lady 55 years, there is nothing in diagnosing a menopause. She is into menopause. But a guy above 40 having andropause, what's the symptom of andropause? Decreased libido, decreased hair growth, decreased shaving frequency, decreased volume of ejaculate, erectile dysfunction, decreased muscle mass, increased fat mass, anemia. So any person above 40, decreased muscle mass, okay, increased fat mass, mild ED, decreased volume of ejaculate, increased fat mass. People don't bother. It is considered as a part of aging. People never check the testosterone. Now the guidelines say that andropause is a concept that is getting very, very strong. Even RSSD 2 papers shows that 58% of type 2 diabetes in India are having andropause. So any person sitting here, or any for that matter, maybe doctors, maybe anyone age more than 35 is think that he's having any features of erectile dysfunction. That is 3 classical features: decreased libido, erectile dysfunction, decreased frequency of morning erection. So any person think that his libido is poor, erectile dysfunction, morning frequency erection is poor, or for that matter, anyone want to check the testosterone, go to any lab before 10 o'clock in the morning and just ask for a total testosterone level. So just by heart, just like HbA1c more than 6.5 is diabetes, 5.7 to 6.4 is pre-diabetic, just tomorrow morning, any day, go to a lab and ask for a total testosterone. Total testosterone value more than 3.5, don't bother, you are pakka normal. Total testosterone less than 3.5, you are at risk of hypogonadism. Among them, less than 2 is diagnosed you have hypogonadism. 2 to 3.5 may be borderline zone. So whenever value above 3.5, you are normal. Less than 3.5, if you want, go to an endocrinologist, repeat a free testosterone with an FSH, prolactin, a total testosterone low with an FSH, low, it is andropause. Previously, people used to wonder, oh, you take testosterone, you land in prostatic cancer. We see ladies getting old like anything, because now many of the studies, international papers says that, colleagues, suppose you are studying for MBBS, MD, whatever, you take your batchmates. So you take your batchmates at 25, 30, 40, 45. Many of the ladies may be looking so beautiful at 45. 55, you go for a batch get together, the mates may be 80% looking fine, but females are atrophied like anything, because postmenopausal HRT, in India only 2% of the ladies take postmenopausal HRT, whereas in the US 80% ladies are actually going to the clinic to continue HRT after 60 years. Here anyone writes an estrogen tablet, immediately the patient, no doctor, breast cancer. Even an endo writes a estrogen replacement for a female with a premature menopause, also people tell breast cancer. So now studies now, WHO and all the US FDA has first time only given a corrective statement in 2025. There is no risk, or the risk for breast cancer in females whichever menopausal HRT is almost negligible. You have to continue estrogen replacement therapy whenever possible up to 51 years, and whenever possible to 60, and men need to check the testosterone. Testosterone replacement therapy in hypogonadal men never induces prostatic cancer. It is testosterone supplementation. Testosterone can be given in 2 ways: replacement. Your testis is not producing, so you are giving. Supplementation, your body is having enough testosterone, you are supplementing for anabolic and bodybuilding effect. So before starting, suppose you are checking tomorrow your testosterone, it is less than 3.5, 2 value less than 3.5, you go to a lab, you confirm that. Before starting testosterone, do a PSA, PCV. These things are very, very important, because men as doctors, I see even HODs, big professors coming and saying, Dr. Bobby, my wife is an yesterday also one doctor, was a very senior, he's owning an hospital. We think that he's very mighty, but he's saying that properly, doctor, me and my wife, we are not having a relation for 12 years. He's 72 years, so 60 years he's not having a relation. He checked his testosterone is 1.2 nanogram. Actually, he was having a difficulty in maintaining erection only, but after 2-3 times, the wife told that, why you attempt for that, with difficulty you are entering and having a premature ejaculation. So 2-3 times the wife told like that, and he is avoiding wife like anything. He thinks that the age is above 62, nothing happens. So whenever your testosterone is low, you look at 2 values, PSA, PCV. PSA more than 4 nanogram or a PCV more than 52%, don't start. It is not the basal PSA, PCV that is important. Repeat the PSA, PCV after 3 to 6 months. Rise in PSA more than 1.5 nanogram per ml always tells that you are having an uncovering of prostatic CA. So always such people you withheld that. And always testosterone previously was given as 3 weekly injection of sustanon. Now it is 3 monthly injection of testosterone undecanoate, that is Serenos Depot is there. And one more thing I want to tell before finish, because even now people come to increase the penile length. A female coming for breast augmentation is okay, because many females have an inferiority complex that breast is not building. Many husbands are fantasized with good breast, so we know that. Suppose a lady gets good breast in 2 ages. One is puberty, second is after pregnancy, because 80% of breast is made up of fat and connective tissue, only 20% is glandular tissue. That's why when you lose weight by Ozempic, there is Ozempic facies, Ozempic boobs, and Ozempic butt, because 60% of fat only Ozempic takes out, so your cheek hollows, your breast atrophies, and your butt hollows. But ladies after pregnancy, some females have so much body weight, 80, 90 kilogram, but breasts are so small, you are giving estrogen, nothing is going to work, because it's not the estrogen that is low, estrogen sensitivity of the breast tissue is low. That's why all the film stars go for breast implant. Just like that, now guys have a trend, they come and ask, doctor, my penis length is poor, so I want to take injection to increase the penile length. Always understand, the penile length depends upon genetic factors, racial factors, as well as the testosterone sensitivity to the penile tissue. So always you mean that. Now the International Penile Index has been published in International Sexual Index. So Africans, average stretched penile length is 16 centimeter. European is 14 centimeter. Indian, the average erect penile length is 12 centimeter. And the smallest erect penile length in the world population is thought to be Thai males, which is 7.5 centimeter. Suppose a guy comes with an erect penile length of 12 centimeter, his testosterone is less than 3.5, you take testosterone, it will benefit. Otherwise, how much ever you testosterone you give, it is the genetic potential and racial factors that is important. It is always important. Whenever a person comes with the penis, he thinks that the penis is small. I always examine the penis, he is having 13, 14 centimeter. 90% of men here never have micro penis. It's your brain concept that is changing. You see some movie, you are comparing, your friend you are comparing, you think that the penis length is low. Nothing. You require a penis of 9 centimeter. I always tell him, a Maruti running 100 kilometers is much more effective than the Benz running 5 kilometers. It is always the ability to maintain an erection with adequate rigidity and duration without having a premature ejaculation. That's the power of the penis. It is not the length of the penis that is important. It is the ability to maintain an erection without having a premature ejaculation. And what about the treatment of ED? Suppose a guy, your age is 50, 55, whatever, you are having erectile dysfunction, first go and take testosterone. Low, treat that. Hypothyroidism, treat that. LDL high, always keep LDL less than 55 or 40. Hypertension, sugar, everything treat. Go for a TMT or a coronary artery calcium scoring. Suppose everything is normal, just like the doctor I met yesterday, 72, testo normal, thyroid normal, lipids normal, OTPT, HbA1c 6.2, PSA normal, calcium scoring normal. Then you know it's an endothelial dysfunction, his age is 72 years. So first and foremost is sildenafil, tadalafil, vadinafil. Among them you ask me, what will you ask for? Will you give Viagra, tadalafil, avanafil or vadinafil? I will give for tadalafil only, because tadalafil has a flight of activity of 36 hours. That is, tadalafil, the PD5 inhibitory effect runs for 36 hours, but many people come and Dr. Viagra and it is not effective, it's not a good drug. Always ask for a 6-hit hypothesis. Whenever you prescribe a sildenafil, tadalafil, ask them to buy 6 tablets of a tadalafil 10 or 20. Ask them to take Monday, Wednesday, Friday, Monday, Wednesday, Friday. Because you take it on a Monday tadalafil, you are not having any hope that this is going to produce erection. You are having increased sympathetic activity. So that sympathetic adrenaline is that it produces vasospasm. Your tadalafil is trying to produce a vasodilation, but your anxiety overtakes. You are asking the patient to repeat on Wednesday. So Wednesday's anxiety is coming down, but the sympathetic activity is coming down, but the vasocumulative effect of PD5 occurs. So he doesn't want sex. He thinks that nothing occurs. He gets up in the early morning, he says small erection, his hope comes up. Because ultimately 2 days, Monday is taking Wednesday, so cyclic GMB is accumulating more. So he's not going for attempted sex. Wednesday, he's taking 30% erection. Friday, he's taking. Saturday morning, he gets up, he's having 100% erection. That shows that his penis is working, and you take it for Monday, Wednesday, Friday, next Monday, Wednesday, Friday, 6 days, the cumulative CGMB is there. What do our people do? They come with all the stress, they come from Dubai, buy a tadalafil, Muslim or everything, take that and go to the wife and having anxiety, nothing worse. Then this drug is bad. Then they go for all the Ayurveda, all the herbal therapy, everything, nothing. Whenever you take a sildenafil, go for a 6-hit hypothesis. Suppose a person tells, this send this to your doctor. He was already taking tadalafil, he went to US and bought Cialis, the best brand from Pfizer and came. So he's taking Cialis 20 milligram, Monday, Wednesday, Friday, Monday, Wednesday for 3 months. With 5 milligram, his erection was good at the age of 58 years. Now 72 years, he's having 20 milligram every alternate for 3 months, still penis is not moving. That means that your endothelium is totally destroyed, your nitric oxide production is not there, so your PD5 inhibitor is not going to work. Then you have to go for a second-line therapy, that is intracavernosal alprostadil. So intracavernosal, you are taking alprostadil, PGE1, papaverine, your prostaglandin E1, papaverine, phendolamine. You have all these powders in the pharma. You can mix it, take in an insulin syringe and inject your penis having a corpora cavernosa. But that is not a practical method. Your wife demands sex more frequently, take an injection every time, injecting in your penis, having a pain, priapism, hematoma, then you cannot move out of the room for 6 hours, sitting there when your children are. This is not a practical option. This is good for people 70, 72 years who wants an intercourse once in 2 months, or for impregnation they want, that is good. Intracavernosal alprostadil. In people where the first line therapy fails, your testo, thyroid, your HbA1c, everything is not working, your sildenafil is not working, who want frequent intercourse, the best option is always going for a penile process. Penile process actually works wonders. How does it works wonders? Suppose your age is 72, 82, your wife is 80, or you are marrying. Why can't you marry at the age of 70, 75? So many Arabs which I see in Dubai, they are 70, they marry young ladies 25. Our society, you don't marry young people. It's your wish. You have money, you have millions in your hand. Why can't you marry? Why can't you enjoy your body? That's it. But at least you should be able to perform the sexual act. Many of the immarital or the conflicts and suspicions in men occurs because they are not confident about the sexual act. A guy who is 100% confident with the sexual act will never have a suspicion with his wife. A person who thinks that his wife is not satisfied with his performance or his whatever behavior, his promiscuous behavior, they only become suspicious about wife. Your confidence only speaks for you. That is why the most disastrous form of sexual dysfunction in young guys is not ED, it is premature ejaculation. PME occurs in the first night, second night it will continue. ED occurs later only after 50 years once your endothelium is destroyed. So this is penile process. Two types of processes. One is inflatable, second is non-inflatable. What is that? It is done by urologist. That's why Rubin Shah is doing that every weekly in a breach candy, all the regime. Here also, your place also, so many people are doing. So inflatable process is nothing. Non-inflatable, you are opening your corpora cavernosa and inflating and putting in the two rubber tube, just like your silicone process. So it is always in the 80% erect process. So anytime you can have an insertion with that. But this is the most important, inflatable. You are opening your corpora and putting a rubber bladder, just like your balloon in this. Here it's a reservoir. The reservoir is filled with fluid. So nothing, your penis is flaccid. Once you want to have sex with, you put on the button on, you just touch your scrotum, put the button on, so the fluid comes and fills in the penis. So that is why we go to Pattaya, Vietnam, Ho Chi Minh and all. We see many of the Europeans with such bulky abdomen going in all the sports cars, cigarette and all. They are going with 2-3 ladies. Our doctors many times when we go for conference, look at this, how these people are going. So we think that our doctors are healthy. They look, oh, these people are enjoying these people. Our doctors are 58, these people are 75, all in the bike and all. All these people come to Bangkok only for process only. They put in these processes. So all are put in these processes. The moment the lady comes in, switch on button, it goes on. The lady is tired. Once he put the switch off, only the fluid will go out. Till then his penis is working. So whatever is coming for the surgery, just like breast implant, and then for the sexual act, our people have a taboo with sex. You tell about testosterone. No, testosterone is sex hormone. Estrogen, good looking ladies, including my seniors. My age is now 45 plus, our seniors 48 years. So much beautiful ladies coming with an atrophic body, hot flushes, urinary outflow, breast outflow, no estrogen at all. Our husbands are looking smart like anything because men go to gymnasium, they have testosterone comes down very slowly. Your andropause occurs at 0.1 nanogram per ml per year. Till 70, 80, your testosterone may be 3, but your menopause occurs on a single day, 48, 50, you're finished. Your menopause is less than 20, you never take estrogen, and females get old like anything. That's why we still say why Shah Rukh Khan, why Salman, why Amir is retaining. They have ended probably andropause. Look at their counterpartners, except Kajal, look at Juhi Chawla and all the partners. They have become old like anything. Probably Kajal has not ended menopause. She's taking estrogen. She's not taking Monjaro to lose her weight. So less than the age of 40. So always understand, less than the age of 40, lean is youth. Above 40, fat is youth. Because less than the age of 40, you look lean, your muscles will protect you. Above 40, your fat will maintain your body, your cheek, your breast, your butt will protect your youth. So ultimately, females need to maintain youth. That is why US FDA gave a corrective statement. All this WHO intervention study which shows that increased chance of breast cancer were done in females above 63 years. WHO. That's why the new study shows that estrogen replacement therapy can be safely given till the age of 60 years. Don't give in person with a family or person history, breast or uterine cancer, unexplained uterine bleeding, DVT. DVT, give an estrogen patch or estrogen gel, give the patient. It will avoid the first pass metabolism and understand the basic concept. And this is the last thing. Now, previously we had only one treatment for treatment of erectile dysfunction, oral treatment, sildenafil, tadalafil, vadinafil. Now, US FDA has approved a new erection gel, that is Erexon gel, that is available in the US since March 2024. It has been launched in India now by Penagra XL gel, by Sidus has launched. So what does it contain? Your Erexon gel contains nothing but Iodex, same like Iodex. It contains glycerol, ethanol and water only. So you apply it 10 minutes before attempted intercourse for 15 seconds. So you are having an erectile dysfunction, you are applying it 10 minutes before intercourse for 15 seconds. What does it act? The glycerol, just like when you apply Iodex, what will occur? A cooling and thawing effect. So the glycerol will produce a cooling and thawing effect so that whatever nitric oxide in the parasympathetic nerve fibers is released and erection improves in 40% of the people. So basically this can be given in people where sildenafil doesn't work, add on to sildenafil, or can be given in people where ultimately you have contraindicated sildenafil, tadalafil. And understand female dysfunction, leave it. Now the last thing is premature ejaculation, Shigra Skalna. What is premature ejaculation? By definition, having an ejaculation before your partner has an orgasm is PME. Your partner has an orgasm at 1 minute, you are having an ejaculation at 30 seconds, that is PME. Your partner has an orgasm at 1 hour, you are ejaculating at 59 seconds, that is also PME. So before your partner has an orgasm, you are ejaculating, it is PME. So PME is divided into two. Primary premature ejaculation, right from the first night of marriage, you are ejaculating 2 minutes, 2 minutes, 2 minutes. It's a genetic hypersensitivity of your pudendal nerve, that is present. Secondary PMI, a person said, doctor, we are married for 30 years, now 50 years my age is, my ejaculated time is getting short. 15 years become 5, now it has become 3, now 1 minute I am ejaculating. It can be due to performance anxiety, learned behavior, exposure to new partner, or testosterone, prolactin, prostate, Peyronie's disease. It is getting more and more common. Diabetic patient, you ask for a penile Doppler, calcific plaques around, tunica albuginea is there. So whenever PMA is there, always, previously what do people do? We write in women's era or whatever, old time, my MBBS days and all, people write in women's era, Manorajya, feminine, and a doctor, I am having Shigras Kalina, what's the treatment? Immediately reply comes, whatever, Yoga Mudra, Ashwini, Vajroli Mudra, and during study of MBBS, it was there, start, stop technique, skews, Master and Johnson's technique, start, stop, and skews therapy, and these all works, because before you think of start, so immediately the ejaculation goes like anything, nothing can be done in premature ejaculation. So people used to, from Dubai, people give them sprays. What are the sprays? It contains nothing but lignocaine jelly for dental anesthesia for PME. So you spray that, is just like an anesthetic patch. So now the treatment of PME is nothing but SSRI, fluoxetine, paroxetine, sertraline, depoxetine. That's a drug of choice. Low sertraline, premature ejaculation. Low serotonin, premature ejaculation. High serotonin, delayed ejaculation. So basically understand, the most common form of sexual dysfunction in young men less than 45 is not ED, it is premature ejaculation. Age more than 50 years is erectile dysfunction, that is endothelial dysfunction. One premature ejaculation occurs, primary, secondary is there, and many people tie a depoxetine with a condom. That is known as a counter return therapy. You have to destroy. Many people, a simple condom itself can prevent ejaculation. Nowadays, some people apply the gabapentin gel. Our GD gel is there for meralgia paresthetica. People apply that GD gel, then apply the condom on that, then the depoxetine. Many times the refractory PME can be controlled. So, and this is the last thing that you need to know. That's why I touched and finished. This is the Eroxon gel, and basically the concept of erection. Why did I touch that when maneuver cold? So basically I can just read the slides and finish it off, but at least understand the concept. Now it is known as a metabolic penis. That is why ED is known as metabolic. Jumani and always gives the talk of metabolic penis. So penile dysfunction or erectile dysfunction is the first marker of an evolving coronary artery disease. I am telling that ED is not erectile dysfunction, it's endothelial dysfunction. A person after having adequate libido in the absence of stress with normal testosterone is not able to produce productive penile erection. That shows that his endothelium is not producing nitric oxide. That's the first marker of an evolving coronary. Before starting testosterone, sildenafil, tenofovir, ask for a coronary calcium scoring, CT angiogram, keep your lipids normal, and there is never an end for sex. Once you want something, go for it. Your partner is there. You have to keep your partner only happy. You don't have to make 100 people happy. Your partner is happy with whatever you are having. Don't attempt for that. Your partner is unhappy. Always go for a good sex. Always go for testosterone and other treatment. Finish.
Yeah, that's a wonderful talk. As usual, like now, Dr. Bobby's talk, everybody sits in the chair. That too, pre-lunch, nobody left. Any questions?
First of all, thanks for, it was a wonderful talk as always. I want to ask one thing, you talked a lot about LDL cholesterol and statin, that definitely is true. But one of the side effects of statin therapy is decrease in testosterone. So would you address that?
So, sir was asking the same question which you used to think 10 years back. Statins reduce testosterone because ultimately testosterone from cholesterol, pregnenolone, 17-hydroxyprogesterone, androsterone, testosterone. So, you know that is why testosterone almost have no role in producing an erection. Erection is 80% endothelial dysfunction. Testosterone has a role in producing the libido. Libido, your drive to have sex. That is why children 8 or 10 years, you are having testosterone 0, you are sleeping with your mother, morning you get up, you are having a tight erection. You sleep like that and go to the bathroom and urinate and your penis comes down, then you go to your mother. So ultimately, endothelium is virgin, it can fire. But testosterone gives you the signal. This is your mother, this is your wife, this is your girlfriend. So testosterone helps in erection by 20%, and statins reduce testosterone by 2 to 5% only. So statins promote erection rather than decreasing erection. So testosterone is just for producing libido, and statins always improve erection by 92%.
If no more questions, we will end the session. Thank you.